Hi, my name is Jasmine Lord, and today I'm presenting my evidence-based practice project in preventing central line-associated infections with maintenance checklists. The purpose of this project is to prevent central line-associated infections, CLABSI, in critically ill patients with central venous access devices, CVADs, within the MICU at Baylor Scott & White Health. Within the MICU, it is common for critically ill patients to require CVADs due to the need for vesicant or vasoactive infusions, poor peripheral access, complicated IV medication regimen, or need for dialysis. The MICU within the last quarter cared for 490 patients with central lines, and the CLABSI rate on average was 10.6%. This can be translated into 52 patients were unnecessarily put at significant risk for increased morbidity, mortality, cost, and length of stay. The goal is to decrease central line-associated infections in critically ill patients with CVADs within the MICU to less than 5%. This practice problem has been identified due to CLABSI significantly affecting patient morbidity, mortality, costs, and length of stay. Evidence found from Kay and colleagues discusses that the mortality rate of CLABSI cases was 49.4% compared to 33.2% for controls. Length of stay was 29.2 days for CLABSI cases and 20.2 days for controls. And lastly, hospital charges were $102,276 for CLABSI cases and $69,690 for control. The clinical question being addressed within this project is, will utilizing a central line management checklist versus not utilizing a checklist decrease the incidences of CLABSI in patients with CVADs in the MICU at Baylor Scott & White Health? Our patient population affected by this project will be patients with CVADs. The intervention performed in this project will be utilization of a central line management checklist per shift. The comparison or alternative factor will be not utilizing a central line management checklist per shift. And lastly, the outcome will be reducing the incidences of CLABSI in the MICU. When discussing the evidence search process, 3 databases were searched: CINAHL, Google Scholar, and Medline Plus. Keywords used for formulating the search on Google Scholar were central line checklists to find evidence supporting checklists for central line maintenance. 25,000 citations were retrieved from this initial search. Inclusion criteria and limitations were relevancy within the last 5 years and only displaying academic journals, were then applied, and then 3,800 citations were retrieved. Many articles retrieved had a level of evidence greater than 3 and were excluded. Many articles were also irrelevant to the project, and due to the abundance of retrieved citations, it was difficult to determine number of relevant articles. Only 2 articles were chosen based on relevancy and having a level evidence of 3 or less. Keywords used for formulating the search on Medline Plus were central line checklists to continue to find evidence supporting checklists for central line maintenance. 32 citations were retrieved initially. Inclusion criteria and limitations, again, were relevancy within the last 5 years and only displaying academic journals were then applied, and 15 citations were then retrieved. Articles were excluded from the search due to irrelevancy and a level of evidence greater than 3. 3 articles were determined to be relevant to this project, but only 1 article was chosen, as the other 2 articles were retrieved from the previous database search. After investigating the evidence for central line checklists, a search was conducted on CINAHL to formulate an evidence-based checklist. Keywords used for the search were CLABSI prevention. Before refining the search, 64 articles were initially retrieved. After adjusting the search's inclusion criteria to academic journals, research articles, peer-reviewed literature, and within the last 5 years, only 27 articles were retrieved. Exclusion criteria was identified as levels of evidence greater than 3, and 6 articles were identified to be relevant to this project with a level of evidence less than 3, but only 3 were actually utilized to support the project due to the content being able to create a comprehensive checklist. When extracting the data, the evidence clearly shows that standardized central line management checklists can reduce CLABSI rates, thus addressing the clinical question that Yes, utilizing a central line management checklist will decrease the incidences of CLABSI in patients with CVADs in the MICU at Baylor Scott and White Health. The data extracted was divided into two categories: data that will support the checklist and data that will create the checklist. The evidence supporting the checklist showed the use of checklists regarding central line management is a valuable tool in preventing CLABSI in ICU patients that may improve patient safety and subsequently reduce costs of hospital-acquired infections. In addition, Sabo and colleagues also agree, stating that an improvement of central line care was observed in all categories after the creation of the checklist. The evidence used in creating the checklist consistently discussed central line infection control bundles that addressed: 1. To remove the central line as early as possible. 2. Maintenance of good condition sterile dressing and change gauze every 48 hours and transparent sterile dressing every 7 days. 3. Change administration set every 96 hours unless used for fat, nutrition, or blood products. 4. Change needleless connectors every 96 hours. 5. Use chlorhexidine-based antiseptic for skin preparation. 6. Utilize disinfectant cap on all ports that are not accessed. With the use of this evidence, a central line checklist was created to address management in a comprehensive manner that reflects best practices. To address the concern of IRB involvement, it was determined that this project does not disclose patient information or have potential in harming patients, making involvement unnecessary at this time. The most appropriate method to implement this project is through the Iowa model. Establishing a sufficient research base is found within this paper. Piloting the change within the MICU is the next step to implementation by collecting baseline data, actual implementation of the evidence-based practice, evaluating the process and outcomes, and modifying the practice guidelines. After evaluation on appropriateness for adoption to practice, the practice will either be instituted or re-evaluated. During the next staff meeting, a sample central line management checklist will be distributed to all MICU nurses to help staff familiarize the checklist and have opportunities to ask questions. Education will be provided at this time, discussing when the checklist will be performed, how it will be performed, where it will be submitted, what data will be collected from the checklist, and when the data will be presented to staff. At each change of shift, both day and night nurses will complete the central line checklist together to ensure management of central line is in best practices. The central line checklist will include assessment of necessity of line, labeling tubing and IV bags with date and time within appropriate time frame, changing CVAD dressings per policy with CHG dressing with date and time, changing hubs per policy, and placing sterilization caps on all ports that are not accessed. Fortunately, this checklist will be low in cost, and the only supplies needed will be paper and a printer to make the checklist tangible to staff. Costs for compensating designated staff members evaluating the process of this project will be more of an expense but drastically less costly than the costs for treating CLABSI. Regarding methods for evaluating practice change, baseline data has already been collected and established. Like stated earlier, the CLABSI rate has remained above 10% for the last quarter. The checklist will be sent to the nurse manager and will be assessed by designated staff members to ensure compliance with best practices. Additionally, rounding of designated staff will occur to ensure compliance. Independently, the CLABSI Practice Council will continue to keep metrics on CLABSI throughout the quarter, and the designated staff member will follow monthly to determine if the checklist intervention has effectively decreased CLABSI rates. This information will be shared at each monthly staff meeting to keep staff informed on progress. Regarding sustaining the practice change, if it is found that the checklist decreases CLABSI rates within the MICU, staff will continue to be engaged through sharing improvement in CLABSI metrics to reinforce staff's remarkable work. Again, resources utilized for this project are inexpensive when comparing costs associated with treatment of CLABSI, making this practice monetarily sustainable. Lastly, this practice will be incorporated into the organization's policies once the pilot is successful within the MICU by establishing central line checklists on other units. I hope you enjoyed my presentation and thank you for your time.